Let's get started. We have a, can we start? Are we ready?
Adelante, Bori, claro.
Okay. So, buenas tardes, boa tarde, good afternoon, everyone. Thank you for joining. This is a very special webinar. We have a very distinguished group of faculty this time. We have Richard Hines, is the brain behind OLIF, and a good friend for Latin America. We really appreciate to have you. We have Dr. Rivera that has a big quantity of case up in San Juan. He's going to be sharing his expertise too. And we have Dr. José Malheiros, an enthusiastic and talented neurosurgeon from Minas Gerais. The three of them are going to be showing OLIF 2.5 to all of us. So without further ado, I'm going to stop sharing and give the mic and the screen to Dr. Malheiros. Before doing that, just one thing for you to note. I see everybody writing on the chat. If you want to do questions, please do it on the Q&A. It's in the middle of the screen of yours. So if you want to make a question for the faculty, please put it there. We're going to select it and read them loud for them to answer. We're going to try to cover as many questions as possible. So, Dr. Malheiros, please go ahead.
Okay, are you seeing my screen?
Yes, perfect. Yep.
Okay, so good afternoon, everyone. I'm José Augusto Malheiros. I'm speaking from Belo Horizonte, Minas Gerais. It's a great pleasure to me to be here with Dr. Rivera and Dr. Hines, Boris. And my presentation, my objective of my presentation here is to give you an overview, a brief operative technique, a brief description of the operative technique, and some indications. Here's a photo with Dr. Rivera and Dr. Hines, who designed and developed with the Medtronic such wonderful technique. I'm very enthusiastic of this technique here in Brazil. Here in Brazil, we are doing such technique since June 2018, about 2 years. And I can assure you that it's a historical landmark in the lumbar interfusion technique. Well, the main features here in the OLIF 2.5, it's a minimally invasive surgery, as it avoids morbidity of anterior and posterior exposures, spare supporting ligaments of spinal column and also the muscle core. It facilitates the placement of large grafts, and with such large graft, it allows you to gain a huge disc height, and then makes an indirect decompression of the foramina as well as the lumbar spinal canal. And such a case can cover all the surface of the disc. It also avoids transpsoas fibers, and it's far away from the lumbar plexus as well, and we not need a specific monitoring for that. And such thing, you do have a direct visualization. It's very comfortable to make the surgery. it's a straightforward procedure, and there is no hurry. I mean, you can do your surgery without with calm. You know, it's great to work in the disc space without a countdown. Well, the three basic topics regarding preoperative assessment is the OLIF corridor, transitional vertebra, and prior vascular procedures. The OLIF corridor, the OLIF is always performed in the left side. So the patient lies in the lateral decubitus with the left side up, and the corridor that we are going to work is the area between the aorta and psoas muscle. You should pay attention in your in the MRI regarding seeing how looking for such anatomy. You should pay attention in L2, L3 abnormal renal anatomy, and L4, L5 as well. You should study the vasculature prior to your surgery. OLIF corridor is wide open in the lateral position. Here is an article that shows how wide such space goes with the lateral position. Here is an example of how you should see this, how you should see your the MRI patients. So here left L3, L4, there is a fat band rounding the vessels. It's an important clue of how such vessels will move anteriorly. Is such a feature means that you won't have any problem with dissection, and we will be able to do the surgery without problem. Here it's a transitional vertebra that it's very close to the space, so we should pay attention on such transitional anatomy. Much for the higher iliac bifurcation, and so as for the iliolumbar vein. So when you have a transitional anatomy, you're gonna see such vein when you are doing the surgery. And another issue of the preoperative assessment is recent vascular procedures, mainly open ones and you should have a lot of scar tissue there with collateral vessels, and you can, in the retroperitoneal dissection can be tough. Well, the operative technique, I'll go on step-by-step technique. First step is the positioning of the patient. The patient is positioned in the lateral decubitus with the left side up. The C-arm is positioned posterior, and the surgeon stands anterior to the patient. It gives to the surgeon a great, a comfortable position for the surgery. And you should also move the table, flip the table until you have a similar symmetric AP and lateral view. So you are able now to make the steps to the skin marking. The skin should be marked 2-3 fingers in the if you want to to make the surgery in the L4, L5 space, and the higher you are in the lumbar spine, more close to the skin mark is closer to the disc space, around 2 or 1 finger from the edge of the body of the disc. The third pass, the third step, after the skin incision, you have to pass through these 3 layers muscles from the lateral abdominal wall: the external oblique, the internal oblique, and the transverse muscle. And you don't have to cut any kind of fibers, and then you can reach the retroperitoneal space. So when you get to the retroperitoneal space, you slide your finger posteriorly, first posteriorly, and then sweep rounding the psoas muscle. You can feel the psoas fibers in your fingertip, and then you can feel the bone structure in the vertebral body. As we progress in OLIF, we start to get used in such tactical sensation of the psoas muscles and the retroperitoneal space. Well, and then you, once you have touched the bony surface, you should make an X-ray and then check with where is your finger, where is the guide wire, and then you just put a guide wire, the dilatators, put the retractor, and your approach is done. It's an animation of this part of the surgery: dissection of the retroperitoneal space, the insertion of a probe. We don't have this probe here, but we make it with a guide wire inside the disc, and then the sequential dilatators, and then the placement of the retractor fixed within the arm of the table. Such step you can put the stability, such pin in the L4 blade. We don't put such pin in the L5 because of the vessels. So always in the level L4, L5, you put the pin in L4, and between L3 and L4 depends on how is your dissection. It doesn't matter, but here you should always try to put in L4. So you open the retractor and your approach to the disc is done. And then you're going to make the disc preparation without, as you are anterior to the psoas muscle, you don't have to worry about the time. So you're now going to prepare the disc, and such part of the surgery is very important. It's such orthogonal maneuver. That's the way how you should move the tools, move your hand to perform the disc preparation and cage insertion, and to avoiding contralateral foraminal injuries. And such orthogonal maneuver, it's orthogonal to the floor of the OR. And then you should check, you can check in AP view there is a clue. It's a small hole in the trial that you should see when you are doing the orthogonal maneuver. It's a small hole in the middle of the trial to make sure that you are in the right position. You are completely orthogonal. And then another animation through such step of the surgery, the annulotomy. Notice that you start the retract is just to view what it's just the beginning of the incision. Then you have to move your hand orthogonal, and then you make the disc preparation. The last part of the disc preparation is the contralateral annulus rupture. After you remove all the disc and you rupture the contralateral annulus, and then trialing and implant. The closure is, you have no difficult here. It's a video that you just move, you just pull out the retractor, observing how the structures are going and going to close your approach. You just have to close the fascia and the skin. You don't have to close all the layers, etc. Here, some indications, some cases of mine. OLIF has as much indications as the lumbar spine pathologies. I mean, since DDD with or without instability until adult deformity surgery and TDR revisions, TLIF revisions, PLIF revisions. Means a very versatile technique. Here's some examples of axial mechanical refractory pain after disc surgery, and then OLIF with good results. Another indication, spondylolisthesis, even a great one like that. After laminectomy, spondylolisthesis as well. Here is an important feature of such technique because it avoids such scar tissue from the prior surgery, the prior posterior surgery. So it's very good to have another option for have a fusion, for example. Here another indication for pseudoarthrosis after infection, after instrumentation, and with a CT postoperative, and 6 months after with a fusion of such level. And it also is great for degenerative scoliosis, as well adult deformity. It simplifies such correction of this technique. Associated with OLIF, we can correct a lot of the adult deformities, like this one. Another great indication, it's for ASD. Here an example of a patient who underwent posterior fixation with PLIF in L4, L5, and S1 with a flat back, and then goes unstable in the adjacent segment disease, segment level. Here, the post-operative, intraoperative control with the cage in the coronal view, and how we make the correction with another instrumentation. And a good, perhaps the first option, I mean, here is some of the best indications for TLIF or PLIF revision of TDR revision, because you don't have to rush. You don't, as you are not inside the psoas muscle, you don't have a countdown. So because you are in a silent space, so it makes the surgery very comfortable. Well, complications is a very safe procedure. I just have use paralyticus with, I have to, in one patient with nasogastric tube and prokinetics, and transient perineal pulse after the procedure, but with no more complications. So the conclusion, I can say it's OLIF 25, it's an historical landmark. Here is the Dr. Hines, that he is the brain of such technique, and such technique avoids soleus muscle, avoids lumbar plexus. It's a great choice for a lot of different situations in the lumbar spine. And why to use OLIF? Because it simplifies the surgery and simplifies the lumbar correction surgeries, and there is no hurry. You can work as you wish. Okay, I think that's it. Thank you again for the opportunity to be here and to talk about a great surgeon that is OLIF.
Thank you, Dr. Malheiros. If you can unshare your screen, that way we allow Dr. Hines to do so. In the meantime, I'm gonna try to translate some of these questions are being answered by Dr. Yamil. So one of the questions says, to release the ALL, which is the most important factor to gain more lordosis, or positioning, anterior positioning, or angulation of the cage? Is not good. I'm trying to translate from Portuguese here. It's not good to release the ALL and put a cage that has only 10 degrees of lordosis. 10 degrees lordosis cage only gives you a 3 to 4 grades of lordosis. Any one of the speakers wants to answer that?
I think this is Rick Hines. Boris, I think it depends on what you're actually accomplishing. If you release the ALL and you've also intend to do a posterior column osteotomy in the back, I think you can put a relatively small implant, because you're going to basically be rotating over the implant to create lordosis. Mm-hmm. And so it depends. And if you are not going to release anything posteriorly and just going to do, for example, percutaneous screws, then I think it would be more important to have a higher lordotic implant in releasing the ALL. But the single most important thing in releasing the ALL is to see it, directly visualize it, and never put anything sharp in that area. And at some point we can show a very safe ALL release technique that's very beneficial.
Okay. Thank you very much. And Dr. Yamil, I think that answers the question that you answered about the severe flat back. So we're gonna move on. Yamil, I'm sorry, go ahead.
Yes, correct. I agree with Dr. Hines. It depends on the amount of correction that you want to have. But doing a release in the front, and sometimes I talked this over with Dr. Hines, sometimes you don't even need to even look at the ALL. You can just start to do some serial distraction of the interspace in the anterior portion of the interbody work, and that will break the ALL. And you can put a big cage in the front, so it's going to do a cantilever moment in the spine. So even then, when you flip the patient and put him prone, it's going to help you to increase the lordosis. And just by closing on the back and not even doing an osteotomy, you can gain some lordosis. If you have a lordotic cage, it's going to help a little bit more. So I think it depends on how much lordosis you want to do for any particular case. You can always add more correction by adding a posterior facetectomy, posterior osteotomy, and continue increasing your lordosis.
Great, great. So we have a lot of ground to cover, so we're gonna move on. Just gonna put this question that opens the gate for you, Dr. Hines, because the question says, which advantages has OLIF 2.5 has over XLIF? So you're ready to go.
Sure. Well, that's a very good entrance. Boris, thank you for having the conference and inviting me. And thank you to all the participants for taking time out to look at the OLIF. And that is a great question. What advantage? Well, I only have 20 minutes. If you want to hear all the advantages of OLIF over XLIF, I need 4 hours. And so we're going to have another conference on the advantages of OLIF. And, you know, I am very biased by OLIF. I started with XLIF, and it was very good operation. And I am not against a transmuscular approach for the right reason. I'm just a proponent for protecting the muscle and the femoral nerve and making the operation smooth and easy with the least trauma to the patient. And that means for most of my patients, the OLIF is a preferred approach, including the 5.1 level. When I started with XLIF, I had a very hard time many times at the L4-5 level with the iliac crest and with the femoral nerve. That was always a war going on. And then we could not reach the 5.1 level, and that was a major level of pathology. However, in OLIF, the L4-5 level, the iliac crest and femoral nerve are never an issue, and the 5.1 is always available. So you can reach all the levels in one's condition. So I'll just say that, and then I'll jump into the talk bars and get through this part, which is really somewhat similar to Dr. Malheiros' excellent presentation that he did. And it makes some of the same points, because we know a lot of the audience is looking at this for the first time. So we want to make sure that you get a chance to see the key points, more of the how-to and some of the structural parts of the operation, not so much, you know, my bias or our bias towards OLIF over another surgical technique. But my last statement would be that when I started OLIF, I thought this would be my operation for multi-level degenerative operations primarily, but it's turned out to be my operation for every single pathology. I find it to be better in every which way. So I'll just move on. Maybe it's not moving down here. So the 025 procedure is basically stands for the oblique lumbar body fusion. The 25 is really about the levels of L2 to L5. And so the anatomy, your preoperative planning, we've talked about some, and we're going to talk about that, how you set the room up and how you position your patient, how you drape or how we drape, the issue of fluoroscopy, how you mark the skin, our exposure, and the retractor placement. Disc prep is important, trialing, and then of course the cage placement is the most important at the end. Wound closure is fairly standardized. So the corridor, we did mention before, basically allows you to do these things. You avoid the psoas completely, you avoid the iliac crest, you avoid the femoral nerve, and you decrease the risk to the ureter and bowel. We'll show you why. So in this study that we did, we went into all the cadavers and showed there was a very good space, a natural space between the anterior piece of the nose of the psoas and the closest vessel on the left, the aorta. The aorta is a very, very strong artery, very like a water hose. You have to work hard to injure that vessel. So that's why we prefer the left side. You don't have to break the table, and there's minimal retraction of the psoas. This is showing the psoas that's going to come back, roll over the pivox plate, and there's a Clydesdale peak implant below in the disc space. And look how beautiful the psoas just rolls back over, so natural in its positioning. And so you can see if you can do this and work under the psoas, there's a lot of reason why you don't need to go through the psoas. It's just not necessary for most of the cases. And so you preserve the integrity of the psoas, you avoid the femoral nerve, and then you're a little more anterior, which gives you some special advantages. So it's a non-muscular corridor. The traditional lateral surgery goes through the psoas. The OLIF is going in front of the psoas and working under it. And compared to an ALIF, there's minimal retraction of the major vascular structures. And that's very different for OLIF and ALIF at the L4-5 level. You avoid the iliac crest by simply moving your incision anteriorly a few centimeters to the anterior border of the disc, and you can completely move around any size high riding pelvic bone, which is really a problem for this. But you can do it with an XLIF, you just have to move your incision. Now the femoral nerve is very, very large. This is a picture of the nerve, very large nerve. It's a confluence of the L2 to L4 roots, and it's really all over the place in the L4-5 disc, anywhere from the posterior to the anterior psoas. So the only way to truly avoid it is to be outside the psoas anteriorly. When you deploy your retractor on the left, when you actually put it in, it's this size, but when you deploy the retractor, the femoral nerve can be pinched between the blade and the transverse process of L5. And so this is why if you're transmuscular and you have your retractors deployed, you want to get in and out and not spend too much time because the femoral nerve is under a lot of stress. But if you are under or in front of the psoas, and the psoas is not under compression, you can keep this open as long as you like. So to protect the ureter and bowel, if you look at the left, you see you've only retracted this much of the peritoneum. The ureter is right here behind the finger and the bowel is right here behind the finger. That's a transmuscular. And on the right, when you do OLIF, you just take the peritoneum a little further away, and then you work in this area. And so you've moved the ureter and bowel further from your actual work, which gives it a little bit more protection. It's always important to do preoperative planning, and we looked at some before. I always get a CAT scan if I'm going to operate on a patient, because I find that an MRI scan doesn't always give me all the information. For example, this osteophyte right here stands out on a CAT scan and makes me think about inflammation in the vessels and their relationships and how could they be stuck or not stuck down. And I also get to look at the corridor very nicely. I get to measure the space of my disc, so I know in advance about what size my implant will be. I know where my psoas is. I map out the arteries and veins. And so if you do this every time, it gets to be something you see every time you start to do an OLIF. And so at the L3-4 level, again, a little bit different anatomy, but if you just had an MRI scan, I don't think you'd appreciate how much of an osteophyte this is. And if you see an osteophyte and you think inflammation, then your vessels might be stuck and not move. And you have to realize some of your tissues may be inflamed and they may not move as easily. Again, we look for the corridor on the left. There's a little one on the right, but that's the vena cava. That's a very fragile vessel. And on the left, a lot of space and a very robust artery. that's hard to injure. And we look at our psoas and our vessels, and as we come down L4-5, you see the bifurcation of the vessels beginning. You see them starting to split. You see the relationship to the corridor. And so now you've pictured everything. And at L5-S1, we see the psoas and the vessels have bifurcated. And now you see your entrance point here. And this is, of course, very important in a revision case like this. When you measure your implant, this is a very important point. On your left, you see that there's an anterior, middle, and posterior dimension to almost every disc space. Well, if you make it perfect in the center and you measured 55, what happens if you're posterior? You might be impinging on one of the posterior lateral elements right here. So you want to be careful that when you measure it, you actually put your implant where you measure it. So if you end up posterior, want to be posterior, you want to go back to a smaller implant. What if you put the implant in slightly oblique? Then you want to be careful because now it sticks out the other side and you can create a contralateral radiculopathy. So if you end up being somewhat oblique, think about if you start at the 55, shorten it, go to a 50 or a 45. This is a beautiful operation for sagittal parameters. So we measure them in advance, and in this case, the SVA was elevated. And so in short term, with the right interbody fixation and the right posterior instrumentation, we're able to do a nice correction with no PSO, no osteotomies at all, just using each of the disc spaces for a distraction and then posterior instrumentation. So it's a beautiful operation for the sagittal plane balance. And at each disc space, you can see you can get tremendous correction in disc space height and also in the angulation, which if you stack them up over multiple levels, many times you can get more of a global correction than an individual correction, such as a PSO or a posterior column osteotomy. When we set up our room, we stand on the abdominal side. We have the legs fairly straight, and when you make the legs straight, it gives you a very good angle for the 5-1 disc. But when you make the legs straight, you increase the lordosis, which is improved over the XLIF where you flex the legs, which flattens the lumbar spine and removes your lordosis. We like to have this position because many of us can work together on the abdominal side. We can see the epidural space and we have less interference from the other instrument. But this is just a picture for you if you start out and you want to start with one setup that works and then modify it to what works for you in your OR. We position the patient, we don't jackknife, and we're very anterior on the table. We position in lordosis. Fluoroscope doesn't move much. We can achieve all levels in one position from L2 to S1. And then we can access both anterior and posterior positions simultaneously. And then I think Yamil, Dr. Rivera has a beautiful way of eliminating the flip that I've actually seen personally, remarkable workflow for the future. And so we don't do this at all. This creates neuropraxia. This is not good. And we just all need to move away from this technique to a flat technique. And it's just plenty of room in there for the surgery. We like to position anteriorly on the table, and that makes it easy to do the work for the surgeon and creates better ergonomics when you work. We also prefer to improve the lordosis by keeping the leg a little straighter, which also gives us a nice angle of approach for the lordosis of the 5-1 level. This was not a concern in the XLIF because there was no 5-1 level, but since we want to get to 5-1, we want to have that access and you straighten the leg a bit. If you stand on the abdominal side, as we see on the right compared to the left, which is more of the traditional transmuscular XLIF procedure, two surgeons can work together very well, and you don't have to bend over the patient. If you don't do that, then what happens is you kind of get in each other's way. If two surgeons are trying to work posteriorly, one can work and the other has to wait. But when you work OLIF, you can work the OLIF anteriorly while the other surgeon is in the back working, And I watched Yamil do this with his team beautifully. So, you know, keep the patient in the left side up, axillary roll, no break in the bed, extend the leg, secure the patient with a cloth tape so it doesn't move around. And this is, of course, a very quick way of looking at it. We have the patient down arm with an axillary roll, and up arm holder for the up arm so it's relaxed. We have a pillow between the legs. The patient has on a little beanbag here in this case to flatten out this area. We tape over a towel, not to the skin. And using this iodoform, it's nice to put that down first and then put tape on it. Then you can really get good fixation and you're never hurting the skin at all. It's a nice little technique. This makes things very, very secure. And then when you're working, the patient won't move around and you won't lose your nice position. It's important to set it up. And once you get, your team gets good with it, it's only about 15 minutes to do this. It's not that long. You don't have to break the table at all. And especially for the 5-1 level, you want to make sure that you prep this very low so you have access to that 5-1 disc. When you drape the patient out, we found it very helpful in the beginning to drape out with a sterile towel your entire circumference, and you want to leave access abdominally in the rare case of an emergency so that you can open up abdominally if you have some major injury. Now I can say, and I should knock on wood, in the last 8 to 10 years, we've not ever had to do this, not even one time, but it's always nice to be prepared. Plus you drape very low to access the 5-1 disc right here. And then what you can do is place the iodoform drape over that, capture the towel, and it gives you a very, very nice, tight, secure, sterile area to work in. From the front, place your drapes. The simple message here is when you work posteriorly, this is the doctor standing posteriorly, you have to move the fluoroscope in and out independently. You both can't look down the lateral tube. But when you place your oblique tube, I can look, and then the fluoro can look simultaneously, and that's very nice. You don't have to work so hard against the fluoroscopy. Ergonomically, if you look at the surgeon on the left doing a transmuscular D-lift or X-lift, the ergonomics are very uncomfortable. The shoulders are abducted, your head's bent, your back is extended, your hands are pronated. So it's not comfortable. But when you make the view oblique on the right, your neck relaxes, your shoulders relax, your arms relax, you supinate your hands, your back becomes straight up. And this is a much more lasting position, especially as you become an older surgeon and you want to be able to continue to do these operations. This is just showing the utility of keeping these tapes and drapes far away, putting nothing here in the front to block your AP view, and then having your X-ray tech prepare to capture the 5-1 angle. Is a significant lordosis, and so you have to really make sure that there's nothing blocking you here for the 5-1 level. When you mark the skin, it's in the beginning, it's good to kind of draw out the iliac crest, this is caudal, cephalad, ribs, feel your rib, and you know this is your working space here. And so then we take the fluoroscopy lateral views, we mark out the anterior posterior border of each disc every time, every single operation, so we know exactly where the front of the disc is. This is exactly where the back of the disc is, its relationship to the iliac crest. And then for a transmuscular, we would used to go right in the center, but for OLIF, we move 5 centimeters anteriorly, and we work out here and work obliquely. That's how voids the iliac crest. And for multi-level, you just split the difference between 2 discs. If you're going to do these 2 discs, you put your incision in the center and just glide back and forth. To expose the L45 disc space, this just shows the small incision. You can see here's the anterior disc space of the disc below. There's the iliac crest line over here. And we're just opening the fascia above the external oblique muscle. And we see the direction of the fibers, see the fingers sweeping in the direction of the fibers of the external oblique. And then that opens it up naturally without injuring any of the muscle or neurological elements. And then the internal oblique, we sweep in the opposite direction. They kind of cross each other that way. And so we don't fight the muscle, we don't damage the muscle. And now you have a nice approach. And the only thing underneath of this is your transversalis abdominis layer. It's like a little trampoline. It's a very robust layer. And so when you push on it with your finger to find the retroperitoneal space, you'll feel your fingers squeeze through it. And then you'll feel the wet fat feeling of the retroperitoneal space on the tip of your finger, knowing that you're in the retroperitoneal space and that you are not in the abdomen. If you happen to go into the abdomen, it's not a big problem. Just take your finger out, close the hole with a small 3/0 Vicryl stitch, and then expose your retroperitoneal space. If you make a large hole in the retroperitoneal abdominal approach, just leave it open at the end, and you're basically working transabdominally. This is showing that after you do that with your finger, look in with a lit retractor. Look in and see, there's the front of the psoas, there's your 4 or 5 discs, that was the 5-1 below. You can see everything. Here's the corridor from the front of the psoas here to the anterior border down here. Look in, move your retractors around, and do everything with direct view, and you won't have complications. You do things blindly, then you'll find yourself having complications. The retractor placement is very important. And Dr. Malheiros, he talked about how you have to align the retractor correctly. This is just putting your first dilator in, and in this case, using a guide pin. And then you do your sequential dilation over the top. And what you're doing with OLIF, you're not dilating inside the muscle. You're pushing the psoas anterior border posteriorly. You're basically pushing it away, and you're clearing out the space between the anterior psoas and the anterior longitudinal ligament. This is giving you your corridor and your access point, and you're going in through the corridor and then under the psoas. And when you work in that place, you're working exactly where you would be if you had gone through the psoas. You're just simply going around the psoas to access that space. But there's several advantages including the view, the ergonomics. We always place the pin cephalad. And Jose made that point that, you know, if you put the pin in the lower hole at the L4-5 space, remember the iliolumbar vein is the segmental vessel of the L5 body, and you don't want to take a risk of injuring that. You see the anterior psoas here, and then you see your first dilator, and when you pull that out, it leaves a nice little hole in the annulus, so you can see where you want to go back in and start to do your work. And then you start to develop your window by cutting through the annulus, widening that, and then increasing your disc access. We highly recommend you always place a third blade. And here you're actually seeing the ureter on the back of the retroperitoneum. So the bottom of the view, this is anterior. And so here's the ureter right here. This is anterior, this is posterior up here. We did the disc work. But if you don't have any retractor like this between your disc and this retroperitoneal tissue, you could injure the ureter. Now it's a pretty strong structure and it's attached to the back of the peritoneum. But if you put a retractor in, then you're protecting this, and right beyond this little thin layer is your bowel. And so it's important to put that third blade in, and it's very important when you're exposing the anterior ligament. You want to align your retractors in the disc space. And so once you put the retractors in, you want to make sure that they line up. The opening right there at the top lines up with your disc, because you're working in parallel to your disc space like this. So this needs to line up so that it opens up right here. And that's one of the only differences in retractor places between XLIF and the OLIF. In XLIF, it doesn't matter, but in the OLIF, it does. When you prep out your disc, just think about this. This is your disc laterally. Here's the anterior disc, and here's where we typically come in obliquely. And you come in and you're working on this kind of angle. Well, if you work in this angle and you don't move your hand up and work in this angle, you're not going to get all the disc out. And most people leave disc here underneath because they don't think about the disc right here, and they leave disc over here. And what that does, it fights your implant. When your implant comes in, it kind of bounces off this, doesn't want to turn, and then gets pushed around by disc material being left anteriorly. So do a complete discectomy. And so remove the annulus and disc on that side. I'm sorry, this is where you leave disc on this side. And if you leave disc down here, when the nose of the implant comes in, it gets pushed posteriorly and could end up obliquely. So you work with up biters to get under, you work with down biters to get this material and clear your disc out. Everything goes well if you've done a complete discectomy. And this is a little different than the XLIF where you just make a hole, take out some disc and shove your implant in. You do a little bit more disc work, a couple more minutes, and you get a lot more options with your implants. So it's worth it. And then the last thing you do is your release of your contralateral annulus, and then your disc is nice and loose. And then when you distract it, you don't implode your vertebral end plates. You protect your end plates. And see, if you left this disc material here, it pushes your implant into an oblique fashion. It gets pincered between here and here. So clear this out, and then when you rotate your implant, you'll be nice and orthogonal. This is showing the annulotomy, annulectomy in front of the psoas, and you widen that. And if you take your time and do that, you get to see with direct visualization into the disc as you do your work. With your Carrison, you can go up under the psoas, and you can actually take out the disc material, and you can also release the anterior ligament. And here's the downside. Get that material on the down bottom side. It's very important. And then make sure you release your annulus under your psoas. You can release it, and that relaxes the distraction when you try to get your correction. And then the very last thing you do is to release the contralateral side. Very last thing, because if you release it in the beginning, then every time you put a tool into your disc space, you might be going through. And so I know the original teachings of XLIF and DLIF were to first go in there with a osteotome and release the contralateral annulus, but I believe you should leave it for the end and from going out, and then when your disc work's all done, then release the annulus. And this is just showing some of the annulotomy. Always with a sharp blade, always position it to move posteriorly. You don't want to cut anteriorly and slip and have a vessel injury. And see that you have a small window now, but if you keep working at this, then the window widens, it gets bigger and bigger so you can see everything. And you're working with the psoas behind the retractor, and there's plenty of time. You don't have to rush. There's no critical structure. See, the window's getting bigger, and we're seeing more. Now, looking in, you can see the disc, and you can see what you're doing, which is so much better. So release the contralateral annulus at the end with any tool that you're comfortable with. I happen to like this blunt shaver because it cuts on the edge, but it's blunt on the nose. A lot of people like to use the osteotome, whatever you're comfortable with, but I really encourage you to think about leaving it intact until the very end and make that your last thing you do. And I just pop it through and release it. It's very easy. Here it is. And I kind of fenestrate it, so I do it a few times. And then I can check and make sure I'm orthogonal. These are old pictures with lead gloves on. I don't do that anymore, but that's for demonstration. And I can tap it through with my hand usually. If you don't release the contralateral annulus, your implant is going to want to push out of the entrance. It's going to be pushed out like spitting out a watermelon seed. So it's an important step not to be forgotten in the preparation before you put your inner body in. The ALL release is a very powerful tool, and you must do it under direct visualization and do it with blunt tools, never anything sharp. And see, looking down in this retractor, take a second, there's the disc, the psoas is up here. You're looking at the ALL right here. We see everything, and here's the third blade. And so we'll just cut the little edge that we see, and then as Yamil described, as we put the distractors in, it just tears. You don't have to cut the whole thing, and you don't have to do anything dangerous or sharp. And when you release it, it gives you more lordosis. If you don't need more lordosis, it's nice to see it to protect it. And then you can put your implant right up against it inside and keep your implant very anterior to get the maximal lordosis and stay away from the posterior area where the neural elements are. This is showing it again. You can see it very well. and here it is blown up. That's a beautiful view. And this third retractor blade slides around very nicely. You don't have to go all the way. This is a very powerful tool in connection with a PCO or a pontine osteotomy, Smith P, whatever you want to call it in the back. Together, this equals a PSO correction at that level. But remember, you're creating a very unstable spine when you do that. This is showing something you're going to see more with OLIF than with XLIF, the sympathetic chain. And it's interesting because here's the psoas, here's the corridor and disc space, and here's the chain, the major part of the chain. There's a little tiny one there. This is almost where it always is. You're going to see it here. So you can do your annulotomy and just leave it alone. You don't have to bother the chain. If you want to release the ALL, do your annulotomy, do your disc work, relax the chain and work in the front and cut it. You don't have to hurt the sympathetic chain at all. Put an Epstein under it. Release it, just like you release a scarred and nerve root, and then mobilize it. Just push it away. And this is showing the pen field moving the chain around on each side of the ALL, and it's very flexible. It's a strong structure. You don't have to cut it, so you won't see a lot of swelling. If you do cut it, it's not a big deal. It won't last long. It's a little bit of swelling and a little bit of increased warmth on the left side. Being anterior is the important part. If you're not anterior, you're not going to be able to do all these things. You can't access the ALL very easily. You can't see the epidural space. You can't stay away from the psoas. So anterior retractor placement is a key feature, and that's what we always recommend. So release with a third blade. So we just cut the top of it, of the ALL, like that. See, we're holding back the chain right there. We just cut the edge of the ALL with the Carrison. We cut it, and under all direct view, perfectly safe. And then the rest of it is done by just distraction. There's no reason to put a sharp tool or sharp knife in there for any reason, not even one time. Don't do it. It's too dangerous. And then you see we're cutting the the annulus under the psoas, releasing that. And now you're really relaxing your soft tissue structure so you get a nice distraction. And then you can see here we've released the annulus, we've released the contralateral annulus, we've released the ALL. The sympathetic chain is still perfectly intact. And look at your view, and we can see the epidural space. You just can't do this with anything but an OLIF. And this shows the local correction in this one case from 5 degrees to 17 degrees just by taking the time to relax the structures and getting a nice distraction of the end plates, not a vertebral body deformity by putting a hyperlordotic implant and just smashing the body. This is a true correction, a true change here. And you can see the pivox plate with the coaxial cage in front of that chain after release. Very, very nice. And here's the psoas, completely content, very happy. Nobody hurt the psoas. When you trial, it's with the pivox, you have the opportunity to change your angles, which is very nice. And so you can get around things. And if you trial and you rotate in a timely fashion, you can place your implant anteriorly, which is a perfect spot for maximal lordosis. If you want to put more angle, you can angle it. And this is just showing some of the tricks of the tools. And this is, again, why it's so important here to have lined up your retractor blade so you can come out. Now we're coming out of the blade. See that? You look up here, we came out of the blade to get the orthogonal position. No different than going straight through the psoas. The cage implantation is important because when you're looking down a tube, you have one hole, you have one option that you put it where you find it. But with OLIF, you're looking across. Look at the view of this disc because the blades are oblique. And so the fluoroscope gives you a much better view. And you'll like to put the implant anteriorly. But there's no problem with putting the implant in the middle. The apophyseal ring is stronger anteriorly, but I question why there's any good reason to be here, because when you put your implant posteriorly, you may be thinking you're getting more neuroforaminal height, but you're not getting any much more than if you put it anteriorly, and now you're risking the neural element. So keep everything anteriorly and you'll be happy. This is showing how fast you rotate and translate. Depends on where your final Pivox implant or Clydesdale implant will be and how it fits. And see, it's a shorter implant anteriorly. If you do this differently, you can actually pick where you want to be, anterior or in the middle, which is so different than just transmuscular. And I would say that try to avoid that. You're going to catch an exiting nerve, and just there's no great advantage, although we all thought about it and we did it for a while. This is the place to be, here or here anteriorly, but your implant size will change. Just to completely avoid that. The speed at which you turn and rotate determines where it goes. If you rotate later, you're going to be more posterior. It's just a trick and it's a tool. And if you look at what you get for it, well, here's your TLIF implant. And that's a lot of work. The TLIF's not a small amount of work to do. Two PLIF implants, look at the size of your structure that you have. Look at your grafting area, and you can graft on the outside too if you want. But you get so much more ring-to-ring support. There's very little ring-to-ring support with these implants. This is why you can't distract them that well. This is a very powerful tool for coronal and sagittal correction because you're crossing the apophyseal ring. This is a nice Clydesdale implant. It's got great anti-migration teeth. If you saw, once you put this in, it will not want to come out. So make sure that you've done a good disc preparation when you put your implant in. The markers are easy to read, and it looks a lot like this. And that's a tremendous change from here to here and not damaging your end plate. That's the key. Retractor removal. Well, at the very end, you just take out the pin, keep your finger on the blade so you don't make it bleed, and then let all the soft tissues just fall back over the top. You see you put a plate on. I like to use plates, and the psoas just comes right back over very nicely and completely intact psoas. When close in layers, you actually put an absorbable suture, reapproximate the muscle so you don't create a hernia. You can do it in that layer, and then you can do the external in this layer. Getting at least one of them closed is important. And then a very nice cosmetic closure. One of the things I like about the lateral surgery incisions is the patients don't see them, and they blend in very well, so they're very cosmetic compared to ALIF incisions, especially at the L5S1. This is a reabsorbable subcutaneous staple, and it makes a very, very beautiful closure. There's no sutures in the skin at all. So if you want to talk about OLIF advantages, I like to have a session of about 4 hours in the future, Boris, where we can talk about the advantages. This was really talking about how to do it and some of the anatomy today. I've taken too much time, so I'm going to stop there. Thank you very much.
Thank you so much, Dr. Hines. So, Dr. Yamil, we're answering some of the questions, but I found a couple that I think are worth to read aloud for you to elaborate on those. So, Dr. Juan, let me take that. Dr. Galareto from Argentina is asking how often they found, or you guys found, vascular malformations in the L4, L5 level.
That's for me, right?
Anyone. You are the experts, so jump in.
Yeah, vascular malformation at L4, 5 is very rare. You gotta see on the MRI beforehand. If you have a transitional segment, then your bifurcation is gonna be higher up. So the iliolumbar vein can be crossing across the L4, 5 disc. So you can get that over there because it behaves like an L5S1. instead of a L4-5 level. So always look in the MRI before, and that way you can avoid it.
Okay.
If you're doing
Dr. Hines, a classic. You go ahead. Sorry.
If you're working at L5S1, you always want to look also at the middle sacral vein that in some patients can be big, and you need to be prepared for it to ligate and cut the vein.
Yeah, I mean, I'll add to that. I think, Yamil, you and I have done likely over 1,000 5-1 levels in our experience. So we've seen quite a few. And I think we probably have done a lot of ALIFs. I did a lot of ALIFs at 5-1 for 25 years before I did this. And so I think I've seen about most of what you're going to see in anterior surgery. And I think your answer was perfect. The transitional anatomy is the key. Some people worry that, well, OLIF, is that contraindicated in a transitional anatomy? And the answer is no. Transitional anatomy is just fine, but you have to understand what's happening. And as Yamil said, if the bifurcation is a high bifurcation, then the iliolumbar vein is going to ride close to the 4-5 disc space. It's perfectly fine to do. You just have to be aware that it's there. At the 5-1 level, situs inversus, you have to think about, there are occasional patients, we've experienced too, where they have the vena cava on the opposite side. And so on the left side of the approach, you can encounter a vena cava if you're not doing your preoperative assessment and looking at your vessels. You'll miss it, and you'll be very surprised when you go in and you encounter a vena cava on your left side. So watch out for situs inversus, and you can always know that's going to happen. Previous renal transplantation occurs many times in this area, and so that would be a contraindication because the vessels make no sense after they hooked a kidney to them. And then, of course, the other anomaly that I've encountered is a horseshoe kidney over the 5-1 space. You can't get in there because you can't do it. But for vascular, a large segmental in the middle will look sometimes just like a left common iliac vein, and you have to do your preoperative viewing axially to know that it's there. You'll see two big, it'll look like two left common iliac veins. But I can't think of anything else anomalous that really stands out. There's some more conversation about going lateral to the left common iliac and the iliolumbar vein, but that's more advanced, and there are advanced techniques that we can talk about in the future.
Dr. Hines, this is a classic for you, and so I'm gonna make it for you. Dr. Ernesto Martinez is asking, do standalone cages are an option with this approach? Then you have your nice story about that patient.
Yeah, well, it is an option, and I did have, I'll tell you, in general, it's an option, but you've got to be particular, and if you want to have success. So try to avoid osteoporosis for standalone because the vertebral end plates are not as strong, and when the patient stands up and axial loads, you could pile on into the vertebral body because it's not strong. I found, this is anecdotal, a high pelvic incidence puts a lot more stress, it seems, on the standalone. And so if you don't require a lot of lordosis and you have a low PI, a low pelvic incidence, it's probably a better patient to do that with, no osteoporosis. And then always add a plate fixation to it to protect against subsidence. In my opinion, try to use BMP and don't decorticate hardly at all the end plate, so your end plate integrity is strong, and always cross the apophyseal ring so that you get the greatest stability and when you axial load. I had a patient that taught me the lesson that came from Trinidad for surgery, and she couldn't afford to go to the hospital because she only had to pay cash and had no insurance. And so we decided we would do her 4 or 5 level OLIF, degenerative scoliosis, with posterior instrumentation in our surgery center, which is a beautiful OR, and then we would find some reason to put her in the hospital overnight for some other reason, and she could afford that. Well, about 2 o'clock in the afternoon, we did the OLIF part. We were going to do the posterior part at the hospital, and she was doing so well, she refused to do the posterior part of the operation because she was doing so well. And so she did very well with a 5-level standalone anterior construct. This is an example of we're learning because the patient wouldn't finish it. I wanted to do the posterior, but over the years she did fine. So the answer is we don't know. And we're learning who are the best patients for standalone, who are not the best patients. I would strongly recommend in the beginning, back up your OLIFs with posterior instrumentation. And when your technique because it is very nice to do standalone surgery, especially adjacent level, but start off with a lot of posterior support to compensate for the learning curve.
Thank you so much, Dr. Hines. Let's move ahead then. I have a couple more interesting questions. I'm gonna leave it for the end. Dr. Yamil,
Okay.
please go on.
Hello, can you see my screen?
Yes.
Okay.
Yes.
So I don't have much left to talk after Dr. Hines and Dr. Malheiros. A very, very good presentation of all the technique, indications, and step-by-step surgical technique. So what I'm gonna go a little bit fast to jump over what is new. We're gonna talk more about how to take a great surgery, which is OLIF, and to make it even better with all the technology that we have right now. So that will mean to do an OLIF with a single position and adding navigation to make it even more predictable and reproducible. So this is the OR setting that we use for OLIF, doing same position and using navigation. So we already went over how to position the patient and how to do the procedure. So this is the setup that we do in the OR. You can see there that patient is on the lateral decubitus, and we are using an O-arm for the navigation part. So my first step here when I started doing navigation is that I wanted to cut the time for preparation when we are doing navigation. When you mention navigation, everybody is a little bit scared or worried that it's gonna take more time to do the surgery. And that was my first concern when I was starting navigation. I thought I was a fast surgeon. I thought I was very efficient, and I thought, well, what can I get new when I use this new type of technology? Is it gonna make me be a slower surgeon? It's gonna be more complicated to start a new technique. But I learned over the time that if you think all the steps and you try to incorporate them on your OR flow, at the end, it's gonna be even more efficient and faster. So you can see here a patient in the lateral decubitus position, and you can see the referenced mark placed on the pelvis. And I do this very early on the prep of the patient. This way, I put that pin in the iliac crest, and we can do an anterior and posterior image with the O-arm and do a spin. Why now? Because with only the 4 drapes and the area is sterile, we can do the O-arm spin, and the OR tech can continue work on the trays in the back. So we take this out of the way very early. So is incorporated in the same flow that we had before using the arm. So this is the way we go from the back and we do the spin while we are starting to prepare all the surgical field. Very important to do a very wide drape and prepare the back of the patient and the front so we can access almost 360 degrees. We can access the spine from the anterior part and posterior part. Always, like Dr. Hines said before, we have the patient with the leg straight so we can maintain the lordosis. If we are working with scoliosis, we can also use a roll below the spine so we can manipulate the spine and try to reduce the deformity with only positioning of the patient. While we are already doing the spin after we have that draped and we have the reference point, the OR tech can start verifying all the instruments. So the instruments are going to have these spheres that you can just show it to the camera and will be automatically recognized. This can be done in the beginning. You can do like a template for all your surgeries. For me, I have a template for OLIF and one template for TLIF. So all your instruments are already saved in the computer, and every time you do another surgery, it's going to be the same. You just show the instruments to the camera, and they are recognized, they are calibrated in a few seconds. So at the beginning, I thought this would take too much time to do, but it doesn't take that much time. It's all incorporated on the same amount of time that it took us before. So after we have all the instrument already in the system, we can start doing the posterior part. So I try to avoid radiation as much as possible. Even if I'm doing an OLIF with my C-arm, I take very, very few shots because I rely more on doing anatomical work. Like you saw on Dr. Hines' presentation, you can see all the structures when you're looking down the tube. So you are always oriented on where you are working, and you know where is anterior, where is posterior, just by looking down the tube. So this is no different. Now, when I do the spin, I only do the one spin to avoid radiation to the patient. So at the beginning, I was doing 2 spins because I would do the cage first, do a spin, put my OLIF in the front, do another spin, and put my screws. But if you start from the back instead of the front, which is the reverse, like for most of us, you can avoid doing 1 spin, so you only need 1. This case is a 3-level surgery, L3 to S1. So we can go in the back and we can start putting our marks on the back for the screws, and we can start putting the percutaneous screws before we put the cages in. That way, the anatomy is not changed during the first part of the procedure. Once you put a cage in the intervertebral space, you're gonna change the longitude of the spine, so the navigation is gonna be off. And of course, if you put the first cage, the second level is gonna be off, but it's gonna be off only in the longitudinal dimension. That is not that important during surgery. You don't need to take another spin for a second level. You can manage looking at the anatomy and continue the surgery, because the most important view that you want is the rotation of the spine and the depth. So those are the dimensions that you need to look at when you're going to put the cage in. So this is very different. Nobody sees a spine surgeon sitting down and doing surgery. So I get to do that. I can sit and I can do the posterior part first. Here it's very important that the camera is either in the head of the table or in the feet. That way, nobody gets in the way of the workflow, and it will not obstruct the view of the camera into the instruments. in my OR setting, I have it in the feet of the patient because in the head, I will put the monitor. We always start from top to bottom, which I think is a little bit easier. This is an actual view of me doing the posterior part first. It's in the same patient we saw before. So I always start with the most difficult ones, which are in the bottom or the right side. So you can do different ways. You can do the skin incision, and you can go directly with the OLIF tap, which is that instrument that you are seeing there, doing the tap for the pedicle. You can also use a guided jam chili needle. With the jam chili needle, you can actually put a guide wire in, and you can feel the bone. So you have a tactile feel all the time, just like if you were doing a percutaneous screw. So in navigation, even though we are seeing very good images and we have three-dimensional images, you always need to think where you're at and have a feeling in your hands. The hands know better than the arm. And your knowledge about anatomy knows better than the arm. So if you notice that something is off, the screw doesn't feel well, you don't feel the good bite in the bone, you gotta check your instrument and then continue. But in this case, we can start from the bottom on the right side. We can put the screw at L3, we do the tap. After we do the tap, we can save a trajectory. So the pedicle trajectory is gonna be highlighted. And then you can put the screw after you do that. In some cases, we can start doing simultaneous surgery. So while I'm doing this part here of putting the screws in the bottom, my surgeon, access surgeon is in the front of the patient. So we can start doing anterior and posterior surgery at the same time. So after we are complete with all the screws in the back, we can pay attention to the front. And this is just another image to review the anatomy, but we already discussed that. The vessels, very important always to look at the vessels. Look at them, the size of the psoas. If the psoas is very large and has a big overhang to the front of the spine, you know you need to mobilize the psoas a little bit. So always be careful about that. When we are going in the back, we already had our screws in the back with all the towers in place, how many levels that you need. We can go in the front. The anatomy is still unchanged. By putting the screws in the back, we did not alter the anatomy of the spine, so the navigation is going to continue to be on the spot. So with the marker, we can go in the front and make our marks in the skin, and we can measure the posterior border of the disc and the anterior border. In that same step, we can, if you want, I don't do this, but if you want, you can measure the depth of the intervertebral space. You can start getting an idea of the length of your cage when you're gonna do the actual implant positioning. So here, this is the same patient. Notice that the reference mark is in a place that is not bothering to work either in the front or the back. So you always have to keep in mind what's going to be your next step. So everything is flawless, nothing is in the way, and you can work without anything bothering you. So here I'm marking the posterior border of the disc and the anterior border of the disc. I have my markings on the skin, and we are ready to do a 3-level anterior surgery. Always, like I said before, the hands know better than the arm. The arm can show you all the images, but always touch the patient, feel the anatomy. The fingers never lie. I always use 2 fingers in the front of the anterior border of the disc, and that would be my entry point in the skin. Here are some examples if you're doing multi-level surgery, how to position the incision. So you can mark a 3, 4, and 4, 5 in the image on here on the right. And you can go from the level of the 4, 5, 3, 4 disc and 4, 5, and you can make an incision from those 2 discs, and you can go to 2 levels on a single incision. If you're going to a 3rd level, you can do a separate incision, unless you are dealing with deformity and working on the concave side of the deformity, then the incision can accommodate 3 levels. Here's an actual case. After we do the markings, we do the approach, go through the 3 levels of the abdominal muscles, we go down with the first dilator. And with the dilator, the yellow line is going to be a projection, so you can point to the area of interest. And remember that in navigation, nothing moves. The spine has a static anatomy. You cannot notice any changes that you do in the spine. So be aware that if you move the spine, you're not going to see it on the images like a fluoroscope. So here, after we put the first dilator, I'm pointing into the disc. There are several ways of going into the disc. You can put that dilator in and then put a guide wire through it and identify that level. Then you can go sequentially with the dilators and eventually with the retractor. If I'm going to do a multi-level surgery, then I need to think what I'm going to do with the anatomy. Because if in this case here, I'm going to place a cage at 4, 5. So after I put a cage at 4, 5, I'm going to change the anatomy of the spine. So the spine is going to be longer, but it's not going to be rotated. So I got to keep that in mind. So what I will do in this case, let's say I wanted to do 3, 4, and 4, 5. I would put a guide wire at 4, 5. Then I'll put my pointer to the 3, 4 level, put another guide wire. So at the beginning of the surgery, I already know where the discs are. So I'm not going to lose that. And then I can start working with one disc, put the cage in, and when I do the second one, I already have the guide wire in. So I'm not going to be lost on finding the next level. It's already marked. So it's just only about thrusting the anatomy and putting down your dilators, moving the retractor to the new level, and do the same surgery in a different level. If we are doing a 3-level surgery, let's say L3 to S1, I would do L3-4, L4-5, and leave L5-S1 for the last. Why? Because L5-S1 is not going to move. So the anatomy is not going to change. Remember that the reference pin is going to be anchored at the iliac crest. So it's in continuity with the sacrum. So the anatomy in relation of the reference pin and the pelvis and the sacrum is never going to change. So that's a tip that the L5-S1 segment never changes. Even if you put a cage at 4, 5, 3, 4, 2, 3, so it doesn't matter. It's not going to change if the pin is at the iliac crest. Here's just another review of the steps going through dilation and putting your retractor in the front. This is a different retractor. This is a new OLIF retractors. And here's the same patient. Like I said before, here I'm marking the L4-5 disc. I have the mark for the 3-4, 4-5, and that triangle down there is my entry point for the L5-S1 disc. And this is the beauty of doing OLIF and combining it with navigation. Now we're doing a 3-level surgery. We already have the screws in the back, and we can put 3 cages in the front without turning the patient. And this saves an enormous amount of time, and it saves material, it saves medication, it saves anesthesia, it saves radiation. So there's always saving time and resources. So in this case, I would do 4-5, 3-4, And after I have those 2 cages in, I can jump to L5S1. I think we'll have another conference for that level in particular. Here's more measuring of using navigation. You can also use neuromonitoring if you want with the dilator when you're getting into the disc. But since we are not going through the psoas, we are not putting the lumbar plexus at risk, there's no use for it. Right now, I don't use any neuromonitoring for the anterior part of the procedure. More images looking at the trajectory going into the disc. And after we get there, it's just the same. Surgery, cutting the disc, using the wraps, taking out the disc, and start to distract the interspace. This surgery is very important to be careful with the end plates. You rely on the end plates and you rely on distraction to obtain indirect decompression, which is the purpose, one of the main purpose of this surgery, to put a cage in the front to indirect decompression and not to bother to go in the back and do a laminectomy or direct decompression of spinal canal. You can do it in multiple ways. You can start with a cob and scrape the disc off the end plates and start doing your release. Like I said before, I try to make things simple. After I cut my entry point and get into the disc, I only use the rasp, which is the instrument on the right side. Why? Because that rasp I can feel the height of the disc once I start turning the instrument. And if I start turning the instrument, I see resistance. I don't go 360 degrees on the instrument because you can break the bone. If you break the bone, you're done because you're not gonna be able to do any distraction of the interspace, and your purpose of surgery is gonna be lost. So you can start, it's a very safe instrument. You can start scraping a little bit of the disc and start working little by little and doing your release. The trick that Dr. Hines mentioned before is very good, to take the Kersen and go all the way back and cut the borders of the annulus. You can increase your window, and at this point you don't need a C-arm, you don't need navigation. You can look through the tube, you can look into the interspace, you can see how much disc you are taking out. So always rely more on anatomy rather than all the other things that are good, but you always need to know where you're at. This is another example of going across with the cob instrument to do the contralateral release. This, I usually don't use the cob to do the contralateral release because if you miss the angle and you put the cob into the end plate, you're gonna break it. So I prefer to use the rasp, and I think Dr. Hines was doing the same in his video. You start turning the rasp, and when you go to the contralateral side, you just make sure you're 90 degrees to the floor, and you tap and go across the contralateral annulus, and then start turning little by little your rasp, and you start doing your contralateral release. With a cob, I think that if the crest is pushing you or you have something in the way, the cob is going to want to go into the end plate of L5. If you break the end plate of L5, you can get a pathological fracture and your case is going to do some subsidence. Then after you take the disc out, you're ready for trials. Do the orthogonal. You can also navigate the instruments and the trial. You can measure the size of your implant. Here, you won't be able to measure the height because the height is not gonna be seen on the navigation because the spine is not gonna move. You will not see any distraction at the intervertebral space, but you can see it through the tube. So it's, again, very important to look down the tube and think how you started. If you started putting a rasp number 8 and it didn't go all the way, Then you start doing your release, then you have a number eight trial, then you progress to number 10, you progress to number 12. It's not gonna show on the navigation, but you know that you can put a 12. So the only measure that you need on that trial is the length and how wide from anterior posterior dimension you need. The distraction is always going to be feeling and looking down the tube. So after you have that, then it's just cage placement. And here you can do the orthogonal maneuver. I find very useful, instead of using the inserter like a pistol, I will turn it 180 degrees with the handle away or pointing to the back. That way, when I start tapping on the inserter, my hand is not on the way.
Dr. Yamil.
Yes.
Dr. Yamil.
Yes.
I'm so sorry to interrupt. We need to close in the next 5 minutes, please.
Yeah, I'm almost done. Almost done. So we can start. Yeah, you can start doing the orthogonal maneuver here, and this is the final cage placement that you can see with the navigation. After we put the cage in the front, then we can just go in the back and measure our rod and do a percutaneous rod placement and lock everything in place. It is optional to do a 3D spin so you can see all the implants and correction. I usually don't do it because I don't want the patient to have more radiation. I will only take an AP and lateral shot just for the record, and that will be enough. And this is just a quick example of an L4-5 disc degeneration with stenosis. This is the position of the patient, placing of the reference mark, and this is what we do, simultaneous surgery. We are putting the sutures in the back. If you notice, the access surgeon already has the dilators in the back. So from there to this point, it takes about 40 minutes to do an anterior and posterior surgery, simultaneous surgery. If I measured it with, comparing it with fluoroscopy and doing the flip, the fastest we can do doing the flip, it will be like an hour and a half to do a front and back. But if you do same position surgery, we can get it down to 40, 35 minutes. And the results are gonna be great. And you can do safe surgery in a short amount of time. And that will be all. Any questions?
Thank you so much. There is plenty of questions. Fortunately, we run a little over time, and I like to make one question before we go, and I like the three of you to give a 2 minutes take-home message for the audience, and if you can share your screen, Dr. Yamil.
Okay.
Here you go, the questions. So recently an article proposed to treat lumbar synovial cyst using, as Dr. Dantas from Belo Horizonte. Recently an article proposed to treat lumbar synovial cyst using OLIF. What do you guys think of this? Any of you?
Boris, this is Rick. In what way? In other words, we're using OLIF for the fusion component and then doing a direct decompression of the cyst, or just stopping the motion by doing an OLIF standalone and the cyst reabsorb. I've seen these presentations. I still remove the cyst directly, even with an OLIF, but there is some expectation that a cyst may spontaneously resolve if you stop the movement. So that's all that I know about it.
Okay.
I agree with Dr. Hines. Once you stop the movement and you do indirect decompression, all that redundancy of the facet capsule is gonna be less. I always try to do indirect decompression, and I tell the patient beforehand that they might need any decompression later on if the symptoms persist or there's some residual radiculopathy, but most of the time you don't need to go back and do a formal decompression.
Great. So just to close, Dr. Hines, would you like to start and give your take-home message, and then Dr. Yamil and Dr. Malheiros?
Sure, Boris, and thank you for an excellent conference and for the attendees to hang in there this long. It's been a long conference, but the take-home message is this is a very valuable, powerful technique. You have to know your anatomy, and you have to be willing to spend the time to study the anatomy, which is not insurmountable. Take the time to get good training. Take the time to develop your workflow and your technique. Go slow, be persistent. Don't be frustrated if you have obstacles. Overcome it, and I believe at the end you'll get a great reward that you will use this operation for the rest of your career for almost everything and every problem that you encounter.
Yes, I
Thank you so much.
Yeah, I think that OLIF for me is a game changer. You can learn your basic, your most common surgeries when you train, but once you start doing OLIF and doing the advantage of it, you can change dramatically your practice. For me, at first I was not that confident on that. Once I started doing the surgery and looking at the results of the patient, my first option is always an OLIF for most of the pathology on the spine, because all the advantage that we mentioned. If it cannot be done, then you have a plan B, plan C, plan D. You can do TLIF, decompressions, and other different surgeries. But OLIF, I think, is the most simple, fastest, with the best results on the options that we have right now. If you are a surgeon that already knows to do ALIF and you are doing some lateral surgery, it's a very, very small step to go into OLIF and get all the advantages of this nice procedure.
Okay. Dr. Malheiros, are you still there?
Take home a message. I think OLIF for me is a breakthrough in the history of the spine, of the lumbar spine fusion. It's a wonderful technique, and you should learn, because you should learn. You have to train this procedure, because it simplifies your lumbar spine surgery. It's easier than, for example, than PLIF or PLIF with less complication and with great outcomes. I'm just have 2 years of OLIF practice, and I'm very enthusiastic in such technique. We should learn.
Thank you so much. Thank you all. Thank you, Dr. Hines, Dr. Rivera, Dr. Malheiros, for your time, for your generosity, sharing this concept with all of us. Thank you all attendees for joining. Have a good night, and see you next week for another Medtronic webinar.
Bye, Boris. Bye, everybody.
Okay, good night. Thank you.
Good night for you all.